Hello, everyone, and welcome to our high-yield blood smears for the USMLE and COMPLEX exams webinar. Thank you so much for joining us. My name is Moses Murdoch. I am a senior USMLE complex tutor with Med School Tutors and Blueprint. I am also an internal medicine resident who is planning to go into hematology. So of course, I'm excited to nerd out with all of you and get you some information that will help you for your boards, but importantly also for real life. Before we jump in, a couple of words about who we are. Med School Tutors is a group of individuals who are med students, residents, fellows, even some attendings who are, one, passionate about the subject matter, about medicine, from the basic science all the way towards the latest clinical trials and guidelines, but secondly, also who really love to work with students to help them achieve their goals. We've been doing this for a really long time. This webinar is just one small piece of what we do in Med School Tutors, and that fits in even to the larger suite of offerings that we have in Blueprint. But I admit that's not why you tuned in today. But if you do have questions about any of these things, you'll see the contact information for us at the bottom of our slides. Please reach out. We would love to chat with you about your specific situation and whether we might be part of your test preparation. A word on what we'll cover today. Really, the focus is going to be on high-yield erythrocyte or RBC disorders through one of the prettiest and also most informative tests that we perform, which is looking at blood smears under a microscope. We'll do this in a case-based format using 14 high-yield images. These are images that I think are likely to show up on your exams and really give you the context around the images so that you can answer those basic science questions, so that you can associate the image with the disease and get you those points that you need. I've already told you a little bit about Med School Tutors, but of course, we'll have some slides at the end that will give some additional information. Please put your questions in the chat. Those questions can be directed only to myself as the presenter, and no one else has to see them. And I will also intermittently be asking you all to participate through the chat. This is a classic sort of tenet of adult learning theory that active participation, active retrieval of knowledge is more likely to encode the information, the facts that you need into your brain. And my hope is to make this engaging and to get you all participating in the chat. If you see me looking down, looking to the side, it's because I am looking at the chat and we'll be monitoring it during the slides so that if you have a question that comes up and I'm able to answer it in real time, I will aim to do that, but we will have a live Q&A at the end of the hour. Some general tips that really apply to any additional information outside of the text of the vignette of your question. And it applies, of course, to the blood smears that we'll be analyzing this afternoon, this evening, but apply to radiology, gross pathology, et cetera. And the big tip here is that don't get freaked out if you don't immediately know what an image is trying to show you. And why is that? And that is because the image is only there to provide additional information. So you should be able to answer the question based on other clues in the vignette, based on the demographics, based on the presenting signs and symptoms, maybe the lab values that show up in the vignette. So use all of the tools at your disposal to aid you in successful process of elimination. The last point on the slide here is more of a learning theory point, which is that the USMLE and COMLEX exams, for the most part, will give you classic presentations of classic pathology, and your job is to pattern match the data that's presented to you in the text and in the images to your mental model of a disease. For example, older individual with crushing chest pain that's worse with exertion and improved with rest. That's a classic story that you map onto your illness script of a heart attack, for instance. And your success will partially depend on your ability to develop a database in your mind of classic diseases that have basic science, pathophysiology, pharmacology facts associated with those diagnoses. And so as we go along, try to keep in mind that sort of classic story so that when you see it show up on an examination question, you will very quickly identify it and then move on to answer the question correctly. On this slide, I'm just showing you broad strokes, cellular hematology. We know that the home of the factory for all of these cells is the bone marrow. You have a stem cell that differentiates over the course of several generations into all of the cells that make up the blood and that live in some of the highly cellularized organs, such as the spleen and maybe even the liver. We know that we can divide these cells up based on markers on their cell surface, that they fall into families such as the myeloid families, the granulocytes, the platelets, the red blood cells, and the lymphocytes, and that this organization can help you understand at what level of differentiation the problem is happening, and the resulting clinical presentation. Again, the focus today will mostly be on red blood cells, but you can see a variety of other cellular elements on the blood smear, and so we'll toss some of those in as well. We'll focus on benign hematology, although nowadays we more often call it classical hematology because these diseases are not all that benign. And the big picture framework for thinking about issues in hematology with respect to the cells is that either you have too few, too many, or these cells aren't working right. And of course, you can divide those up by the hierarchy that I just mentioned. We won't be talking about disorders of coagulation, but of course, that falls under the hematology framework. Outside of benign or classical hematology, we also have malignant hematology or oncologic hematology. Liquid oncology is another word that folks might use. That's really the world of leukemias and lymphomas. We had another webinar recently on those diseases, so they won't be the primary focus today, to give you a diverse sort of set of information in this webinar. On your screen right now is a normal peripheral blood smear. Keep in mind that the way this is done is you have a drop of blood, it's put on a slide, you have the cover slipped, and you smear it out. And you're really looking at a portion of that smear, the feathered edge, where you have sufficient separation in the cells that you can accurately pick up on the morphology of the red cells, the white cells, and the platelets. And that really is the organization for looking at a peripheral smear. You're looking at each of those cellular lines. You're looking at the size of the cell. You're looking if there are deformities in the appearance of the cell. Are there too many or too few? Here I've pointed out with arrows the key cellular components that you can see on a peripheral smear. The red arrow is pointing to a red blood cell, right? And this should be the predominant cell that's seen on a peripheral blood smear. A normal red blood cell is biconcave, and it has that area of central pallor, which should be, somewhere around a third of the size of the red blood cell. Of course, this is a hint that we might see abnormalities in the shape and the amount of pallor that the red blood cell has. And the white arrow is pointing towards a white blood cell. And in this case, you see a multi-lobed cell and a few examples of it throughout this smear. This is a granulocyte, probably a neutrophil. And of course, there are a variety of other granulocytes like eosinophils, basophils, macrophages that might show up on your blood smear. And the sort of bluish gray arrow is pointing towards, and I know it's tough to see, but it's pointing towards a platelet. These are relatively smaller, and you can assess whether there's too many of them or too few. Sometimes you see a really large platelet or perhaps even a megakaryocyte, and that might give you a sense of whether there's pathology going on in the world of the platelets. Okay, so now that we have our normal, we're going to show you examples of abnormal and test you on some of those associated diseases. Okay, so let's jump right in. Here we have our first image. It's more zoomed in than the last one. And what I want all of you to put in the chat is this cell right here. I'm going to point out a couple of examples. What finding, what buzzword is associated with this smear. And I'm going to give you all a few moments to think about that. I'll keep a look in the chat. I already have one person with that's on the right track. A few more seconds. And yes, what this is basophilic stippling. The image in the top right is just a reproduction of what was on the last slide. Key point here, basophilic stippling is on the peripheral smear, but you might see in one of your exam questions what's in the lower right, which is another finding in the bone marrow, right, where you have ringed sideroblasts, sort of a version of this in the bone marrow. There's a variety, it's not specific for one disease. On the slide, you'll note a couple of the diseases that can be associated with basophilic stippling, things like sideroblastic anemias, of which lead poisoning is one of those causes, as well as myelodysplastic syndromes, which is sort of a pre-malignant state in the bone marrow that can be associated with macrocytosis and ring sideroblasts, as well as thalassemia, of course, a disorder of heme synthesis. Why does it look this way? The stains that are used to visualize the stippling identify ribosomes that are not working right. And remember that some of these diseases, like lead, for instance, there is disruption in protein production, and therefore it shows up this way on the peripheral blood smear. Text that is in red are high yield associations that are either directly related to the peripheral smear or more distantly related. And this is where I'd want all of you to get involved too. In lead poisoning, what are the two enzymes that are classically taught to be inhibited? So the two, and name, if you know both, put both down. If you only know one, put what you know down. Feel free to guess. I'll give you all a couple of moments to put it in the chat. Appreciate the folks who are participating. And that's exactly right. So two answers here, furochelatase and ALAD are two that are inhibited by lead. And of course, there's the several steps in the in heme synthesis that basically lead to these findings. But disorders of that pathway can also lead to porphyrias, for instance. Okay, and how about this? What is a medication that is used for the treatment of tuberculosis, TB, that can lead to a sideroblastic anemia? So which medication that is used, part of the 4-drug therapy that's commonly tested? Give folks a chance. Yes, wonderful. So isoniazid. Recall that in the treatment of TB, this is a slow-growing sort of fastidious organism. You can use rifampin, isoniazid, which is the answer to the question, as well as ethambutol and prosinomide to treat TB. So that is excellent work, everyone. On to our next smear. Here's another image. And what if I said that this is a patient, an older patient that's had some weight loss, and let's say that they're anemic as well, and perhaps they haven't had a colonoscopy in a while, but they've had some blood loss. What sort of diagnosis does that clinical picture bring to mind? I'm already seeing one correct answer. What we're seeing here are microcytes and hypochromasia, and that's a classic finding for iron deficiency anemia. And just like I mentioned in the past slide, this is where you have states of chronic bleeding. So GI bleeding is very commonly tested, but you can have chronic bleeding from other sites. You know, GU bleeding far less likely than GI to be mentioned in a vignette, but of course you can see that. The lab values that would be associated here would be a low iron, a low ferritin, right? High total iron binding capacity. And on the right, there are a bunch of different findings that you can see here. You'll notice that the central pallor seems enlarged. I mentioned it should be about 1/3 or so, and here there's just way too much pallor. The second thing you'll notice that there's small cells and there's large cells, right? And there's abnormally shaped cells. So there's a number of different abnormalities on this peripheral smear. There's a word, poikilocytosis, which refers to varying sizes, varying shapes that can also be seen with microcytic anemias, and here iron deficiency anemia. Wonderful. There are a couple of unique symptoms that patients will report when they have really low iron, right? So iron deficiency anemia, it leads to some interesting symptoms or behaviors that patients might have. This is a bit harder, but in the chat, go ahead and put in what sort of symptoms might a patient report to you that would raise the red flag for iron deficiency anemia. Yeah, that's perfect. So fatigue, pallor, that's the common stuff. Glossitis, sometimes patients can have. Pica, perfect. You know, so folks who chew on ice, for instance. And then sometimes you can have cracks in the corner of your mouth, chiliosis. None of this is like super specific, but if you see it in the appropriate clinical context, maybe a smear like this, then your suspicion should be raised that you're dealing with iron deficiency and a microcytic anemia. Awesome. Here we have our next image, pretty classic image here. The first question for you all, what is the name of this red blood cell abnormality? And I've got a few folks chiming in. Perfect. Yes, these are target cells, right? And I've given you some of the ways in which it might present. But what I'm going to ask you all is to rack your brains and put in the chat, what are the diseases in which you might see target cells? And I'm already seeing one answer. I'll start calling them out as folks put them in the chat. So yes, thalassemia, that's a big one. It's probably the most common. Another correct answer, perfect, is hemoglobin C disease. It's another hemoglobinopathy. Less commonly tested than the other thalassemias, but absolutely. I'm seeing, thinking about an organ in the right upper quadrant and in the left upper quadrant. The one I'm already seeing is liver disease, but also asplenia, right? And so the mnemonic that sometimes comes up is HALT, H-A-L-T, and these are all diseases that you put in the chat. Now, the connection with sickle cell disease is, remember that in sickle cell disease, you can have autoinfarction of the spleen, right? And over time, that could lead to the asplenia, and so could therefore lead to target cells. Of course, if you have trauma, this might come up on your surgical clerkships. If you have abdominal trauma, motor vehicle accident, the patient is exsanguinating, you need to get rid of the spleen. Or for instance, if you have a patient who has really bad hemolytic anemia and the macrophages in the spleen are busy just chomping up all of the red blood cells and you need to have a splenectomy, those are a couple of ways in which you could end up with no spleen. And of course, there are very rare disorders where genetics play a role. Okay, moving on. Image number 4. What is the name of this red blood cell abnormality? And I'm already seeing a couple of answers. Thanks to everyone who is participating. Yes, these are acanthocytes, also called spur cells. Lots of text on this slide. I'm going to try to walk you through it and then test you on something that's pretty niche. This big picture can be seen with liver disease, which is the common answer here. There is a very rare genetic disorder called A-beta lipoproteinemia that can have acanthocytes. And so that's one of those basic science things that you'll probably, depending on what specialty you go into, you'll probably only see on the boards. But it's good to know because it's easy points if you can identify it. And specifically for the A-beta lipoproteinemia, you know it's genetic, so you suspect it's in a younger age range. You see a very nonspecific failure to thrive. You have a failure of fat absorption. And all of that ends up leading to neurologic symptoms. So things like spinocerebellar degeneration, which of course leads to a presentation of ataxia. And then of course you can have other nerve issues, remembering that the optic nerve can be affected and leading to retinitis pigmentosa. And of course, the why does it look this way? It's not a terribly revealing answer because this is the answer for basically every red blood cell disorder. But of course, it's because you have membrane dysfunction, remembering that some of these vitamins are, and of course, lipids are key components of the cell membrane. When they're missing, you don't have that really nice biconcave disc shape that you're expecting to see. Like I mentioned, the demographic is infants, and why is that? Well, it's genetic, it presents early. And here's the question for you. What two genes or proteins are defective in A beta lipoproteinemia? Go ahead and put that in the chat. While we're doing that, I'll just respond to a really excellent point made in the chat, which is, and this is a tough one, it's what's the difference between spur cells and Burr cells? Burr cells, they sound super similar. And I will defer the answer to that in a second. The clue is that it has to do with how regular and how uniform the projections from the red blood cell membrane are. And of course, someone already beat me to the chat. Acanthocytes, spur cells are irregular or more irregular, whereas the Burr cells, as we'll see in a few slides, more regular. And they're associated with a distinct set of diseases. Okay, I'll go ahead and give you the answer for this one. Really tough. So ApoB48, ApoB100 deficiencies, of course, these are autosomal recessive, can lead to A beta lipoproteinemia. You don't really need to know that much more beyond what's on this slide for A beta lipoproteinemia, but if it shows up on your exam, that's something that you can answer quickly and then keep it moving. The treatment, incidentally, for A beta lipoproteinemia is high doses of vitamin E. And that sort of makes sense because vitamin E and vitamin B12, they're really integral for nerve cell integrity and health. Recall that both B12 and vitamin E deficiency can lead to dorsal column disease. So it's not surprising that its supplementation may help in a case like A beta lipoproteinemia. And then just because of the nature of the defect, restrictions in the ingestion of long-chain fatty acids can also be helpful. But of course, the ideal would be some sort of genetic therapy, which is all the rage now in the research space. All right. Next question here, and this is a must-know image. This is super high yield and very important to get on your exams. Go ahead and put in the chat what you think it is. And I'll answer while you all are putting in the chat what these are. I'll answer something else that came up in the chat. I'm not totally sure what shows up on step 3, because one, personally, I have not taken it yet, and also because I don't tutor for that exam. But I suspect that a knowledge of this basic histology, especially if it's something that's performed in a clinical pathology lab, fair game to be tested. But I would consult with someone who's taken the exam to confirm that with you. All right, thank you all for putting your thoughts in the chat. These are in fact schistocytes, the so-called helmet cells. And I'm going to use my mouse just to highlight one here. Very classic morphology here, the schistocytes. And I'll first cover what causes schistocytes, and then we'll go to the diseases and some of the basic science facts that you need to know. So schistocytes can happen either with microangiopathic hemolytic anemias, and that's going to be your next question to put in the chat. What are some diseases that are MAHAs, microangiopathic hemolytic anemias? And I'll give you one that you can also see this in macroangiopathic hemolytic anemias. The classic disease there is where you have a prosthetic valve of some sort. So the patient needed a prosthetic valve, but as the red blood cells flow through that valve, they are sheared by the valve, and you can see a presentation like this on their peripheral blood smear. On the screen, you've seen several answers to this. TTP, thrombotic thrombocytopenic purpura, HUS, hemolytic uremic syndrome, HELP, which is a form of severe eclampsia, right? Hemolysis, elevated liver enzymes, and low platelets. But there's a couple others that are up there: sclerodermal renal crisis, DIC, and mechanical valves. Exactly. So as put in the chat, mechanical heart valves, like the mechanical aortic valve, can lead to a macroangiopathic hemolytic anemia. And here's the key. What you're looking for is that the combination of anemia, thrombocytopenia, and schistocytes. That trio should trigger this differential diagnosis. And the question for you all to answer in the chat is, what gene, what protein is defective in TTP? Bit of a funny name. Like many gene names, it's a jumble of letters and numbers. But go ahead and put, what is the protein that is dysregulated? Perfect. So it's ADAMTS13, right? This is a multimeric protein. And when this metallic protease is missing or defective, you end up with TTP. Here's another high yield tip. Once you arrive at a diagnosis of microangiopathic hemolytic anemia, you might think your job is done. But as this slide shows, that's the beginning of the journey, right? Because you need to figure out which one of these diseases it is. And one common branching point that you need to essentially establish for the vignette is whether you're dealing with DIC or TTP. And remember that DIC has derangements in your coag panel. So that's your PT, your PTT, and your INR. Whereas, so that's in DIC. In TTP, you tend not to see those coagulopathies. HUS, the uremia should be a clue. Usually you have renal dysfunction, bad renal dysfunction, right? And there's usually an inciting event, like an E. coli infection. Perfect. So schistocytes, really remember this slide and the associated diseases. This peripheral smear should have seemed familiar because we were just talking about it in the setting of the acanthocytes. Notice that the projections are a little bit more regular. What are we looking at here? What are we looking at? We've got one correct answer so far. Don't be shy. Go ahead and put it in the chat. Your best guess. I will say that this is not the right answer, but like you could maybe convince yourself that this here is a schistocyte. And that also makes the point that for the purposes of your exams, they will show you classic pathology and they will show you, there's only one right answer, essentially, is what I'm trying to get at. But in real life, sometimes you can see the occasional schistocyte. And the truth is that there are more advanced criteria about how many schistocytes you see in a high-powered field. But I don't want you to worry about that. There will only be one correct answer for any vignette that you have. So as correctly put in the chat, this is an echinocyte, also known as a Burr cell, right? The most common diseases that lead to echinocytes or Burr cells are end-stage renal disease and liver disease, so two big organs in internal medicine. And the more basic science one is that there is an enzyme involved in energy metabolism, deficiency in which can lead to echinocytes. And so if you remember, and you all are too good, yes, someone has got the right answer in the chat. I'll give a couple more seconds for folks to chime in here. And I'll just point your attention to the distinction between Burr cells and acanthocytes, which is that the Burr cells they tend to be slightly smaller, the projections, and they're more evenly spaced, they're more uniform. So of course, this is pyruvate kinase deficiency can lead to the finding of echinocytes. Wonderful. All right, here we have another blood smear that is abnormal. And now I will point out, because there's a couple of different things here. What I want you all to focus on is the fact that there's a bunch of these cells that are maybe slightly smaller, I'm pointing them out with my cursor, and they don't have any central pallor, okay? And while you all are putting in the chat what the name of this abnormal red blood cell looks like, I'll just point out that this slide has this cell over here that's a bit larger. It's deformed, it's a bit larger. And maybe this one up here, they're larger and they tend to be slightly bluer. That's probably a reticulocyte, right? An early red blood cell. And there is a cell that sort of looks like a rectangle almost, or an ellipsis. And let's say there were a ton of those, and that was the predominant finding. You could maybe make a diagnosis of hereditary elliptocytosis, but that's not what we're seeing here. We're focusing in. I'm just cluing you in on the right direction here. The predominant finding are, as put in the slide, spherocytes, right? And so spherocytes can be due to hemolytic anemia, and there's a whole differential for hemolytic anemias. You know, you can have things in the external environment that are destroying the red blood cell. For instance, the aortic valve replacement that was mentioned in the chat not too long ago. You can have pathology at the cell membrane. So for instance, an autoimmune hemolytic anemia. And if you look at the bottom of the slide, there's cold versions of this. In other words, IgM, pentameric immunoglobulin mediated, such as in CLL, in mycoplasma, or in EBV mononucleosis, or warm hemolytic and autoimmune hemolytic anemias, such as can be found in CLL and in lupus. Notice that CLL could lead to either one. It's not a big deal. But in addition to that, you could have something like PNH, paroxysmal nocturnal hemoglobinuria, which is caused by a defect in a protein that inhibits complement, right? CD55, CD59, PIK-A gene. But what I want to focus your attention here is on hereditary spherocytosis, because there's a pretty common basic science tie-in that can be tested. So what I want you all to put in the chat is, what are some of the membrane proteins that can be defective in hereditary spherocytosis? There's a couple of correct answers. Just go ahead and pop them into the chat. Beautiful. Spectrin, ankyrin, wonderful, excellent. I would say that spectrin and ankyrin are probably the most commonly tested. There's a range of answers, and they're constantly adding to the genes. So what I put here is probably out of date with respect to the latest that you could find in PubMed. But I think spectrin and ankyrin are the most common ones. But you can also see mutations in the protein pallidin, band 3, protein 4.2, and folks are putting in the chat other correct answers, but that is perfect. So hereditary spherocytosis. Keep in mind one other lab value that we skip over in almost every other disease, but in this one, hereditary spherocytosis can be significant, is the MCHC, right? So the MCHC can be high. All right, we're making excellent time here. Here's an exception to the rule. I told you all I was going to focus predominantly on benign or classical hematology, but this one is just too classic to miss out on. And I have to put it in here. And folks are all over it. This, of course, is rouleau formation. And I had the question marks in red that highlight the main disease, which is what? Go ahead and put it in the chat. What disease classically causes rouleau formation? And that's exactly right. This is multiple myeloma. And remember, in that first slide, I mentioned coming up with an illness script for some of these diseases. What are the clinical features, the lab features that would make you think of multiple myeloma? So if you had to, perfect, I see it in the chat already, CRAB, right? So hypercalcemia, high calcium, and an extra little pro here, a low PTH, because this is a PTH independent process. It's coming from the multiple myeloma actually releasing it from the bone, so a low PTH. So hypercalcemia. You have renal disease, right, with Bence-Jones proteinuria. You have the anemia that comes from multiple myeloma, and then the bone pain. And this is why we get, well, one, it's why sometimes we diagnose multiple myeloma, in folks who are getting imaging for other reasons. We didn't initially perhaps have multiple myeloma at the top of our differential, but we see a lesion, a punched out lesion on a chest x-ray or on a KUB or something. And it leads us to the diagnosis of multiple myeloma. Wonderful. Some of the other tests that you might see, depending on which level of the exam you're taking, is testing for a serum protein electrophoresis. So you're looking for that M spike. You might look at free light chain ratio. Remember that when immunoglobulins are made, they are made with either kappa or lambda light chains. And if you see that you're making way more kappa or way more lambda than of the other, then that suggests that there's one clone, one malignant clone, plasma cell clone, that is just pumping out immunoglobulin and skewing the ratio, suggesting again that clonal process. And that can help you track how the disease is going as well. And an additional little clinical pearl here, the reason that proteasome inhibitors like bortezomib, like carfilzomib, the reason why they work so well is because these multiple myeloma cells are factories that are operating at 100% capacity. And just like anything that's operating on the edge of productivity, they are on the verge of collapse. So that if you inhibit the recycling mechanisms, right, the proteasome helps recycle defective proteins in the cell. If you inhibit that multiple myeloma cell will tip over the edge, and that's why it can have efficacy in treating multiple myeloma, in addition to all the other therapies that are constantly evolving for multiple myeloma. The basic science correlate to all of this is that when your blood is just chock full of protein, the electrostatic charges of having all of that extra protein is what actually causes the rouleau formation, the stacked chips, so-called. Okay, excellent work, everyone. On to our next smear. And here we're really focusing on the number of lobes in this neutrophil. What are we seeing here? Go ahead and put it in the chat. I'm going to be monitoring the chat here. Love it. Got one correct answer. Folks are, just for your information, a neutrophil should have somewhere between 2 to 5 lobes. And if we count them here, 1, 2, 3, 4, 5, 6, 7, maybe if you count this one, 8, maybe 9. 1, 2, 3, 4, 5, 6. So again, this is a hypersegmented neutrophil. You can see this with megaloblastic anemias, right? And specifically folate and B12 deficiency, as well as medications like phenytoin, like methotrexate, and with alcohol abuse. And so here's the question for you, because the up and down arrow questions can be rather difficult. Which deficiency has increased homocysteine, but a normal methylmalonic acid? That's what MMA stands for. So increased homocysteine, but a normal methylmalonic acid. We're looking for a vitamin deficiency. Most commonly, it would be folate. Remember that B12 has elevations in both homocysteine and methylmalonic acid, whereas folate has increased just in homocysteine. We don't have time really to look at the full pathway now, but it has to do with exactly where, which enzymes are affected by these deficiencies. Wonderful. Folate and B12 in that order. Hypersegmented neutrophils. Okay, here is a disease with an incredible burden of disease. Folks come to the hospital frequently, and there's recently been a lot of changes, advances in our ability to treat this disease with genetic therapy, or at least that's the promise. And what we're seeing here are like thin, sort of needle-like red blood cells. Folks in the chat, absolutely correct. We are looking at sickle cells and sickle cell anemia. The presentation here is really important to recognize because most commonly you have a vaso-occlusive pain crisis where these red blood cells, when they are in hypoxic conditions, they sickle and they can lead to obstruction in flow through the smaller blood vessels. And that can lead to infarctions in areas of the bone and lead to vascular necrosis. It can lead to, as I mentioned earlier, asplenia, which could lead to target cells. And of course, it's just extremely painful. Treatment is hydration and treating any volume depletion. The feared complication here is acute chest syndrome. This can be a highly morbid, if not fatal, complication. You see that with a pulmonary infiltrate fever in the setting of sickle cell disease. And the treatment there would be exchange transfusion. And of course, when you have autosplenectomy and functional, if not surgical asplenia, you are susceptible to infection with encapsulated organisms. Streptococcal sepsis can be fatal. So you have to be able to identify it in the real world. Really important to pick up on any sign of infection in patients with sickle cell disease. Couple of really nitty-gritty questions here because y'all are so smart. You're getting all of these answers. What is the amino acid change in hemoglobin S? So in other words, hemoglobin S is the name we give to this mutation. What is the actual amino acid change? What is changed to what? Go ahead and put it in the chat. Awesome. Glutamic acid to valine. And next, what is the treatment or one of the treatments for sickle cell disease? Folks have been putting it in the chat. Absolutely. Hydroxyurea increases the fraction of hemoglobin F, fetal hemoglobin, which is protective and is one of the mainstays of treatment. By the way, hydroxyurea can lead to a macrocytosis. And so that can be one way that we actually monitor how folks are doing on hydroxyurea. There has been a revolution underway in the treatment of sickle cell disease. Obviously, this is a big issue in terms of health equity. Gene therapy is being studied, but there's also new treatments like oxalator, also called Oxbryta, as well as a monoclonal antibody against P-selectin called crizanlizumab. This is stuff that will possibly show up either on shelf exams boards or the STEP complex exams, depending on how quickly the test writers incorporate them based on the HOPE and the SUSTAIN clinical trials. Excellent. Here we have two images that relate to the same disease. What is the name? What is the name here for this disease? Or the red blood cell abnormality that's found here. So absolutely, these are bite cells. And on the right, we saw Heinz bodies. And the classic association, you all are too fast, already put it in the chat. What this is G6PD deficiency, right? The Heinz bodies themselves are denatured globin, because again, remember, G6PD has to do with management of oxidative stress. And when that is not controlled appropriately, you can get denaturation of proteins, of which globin is a key one. And that denatured globin leads to the Heinz bodies, the phagocytes, maybe in the spleen, recognize this abnormality. They go ahead and chomp a little piece of the red cell membrane, and you end up with a bite cell. And so that is the classic sort of story of the pathophysiology of G6PD deficiency. Of course, key to remember the triggers for G6PD. Fava beans is one that's I've never seen actually clinically, but it shows up. The one that comes up in hematologic cancers that's really important is, let's say that you have a patient that has acute leukemia and they're coming in, their white count is just impressively high. We're talking 200,000 cells. And let's say it's an acute leukemia, and these cells are lysing and they're releasing potassium, they're releasing phosphorus, they're pulling down the calcium level, and importantly, they have very high uric acid levels, and you're worried about them having kidney injury or kidney failure. There is a drug that you can give, an enzyme that you can give to treat tumor lysis syndrome. And that enzyme is called resveratrol. And if you need to test for G6PD before you give resveratrol for similar reasons, because you can precipitate a complication in those who have G6PD deficiency. So again, a bit of an advanced topic, resveratrol, in addition to other drugs, antibiotics, fava beans, etc. Excellent work. And it is excellent for recessive. I forgot to ask you, I got carried away with my tumor lysis syndrome teaching. Excellent for recessive disease, G6PD. Awesome. All right, here we have some odd looking cells. I'm pointing it out here. As you all are thinking about what this might be, I wanted to point out these little guys right here. These are the platelets. These are the platelets. And by the way, I'll put a small plugin for a question that came in through the chat. There was the question of the Racket cells that can be associated sometimes with Burbick granules. Remember that that is an association with Langerhans cell histiocytosis. And that's usually seen more on electron microscopy than it is on a peripheral blood smear. But the shape is right, so you're on the right track there. Folks in the chat correctly pointing out that this is a dacrocyte, or also known as a teardrop cell. And just recalling the reason that it looks this way is because there is fibrosis of the marrow. If you took a biopsy of the marrow, you could stain it for reticulin and see the increased amount of fibrosis markers in the bone marrow. And you can think of these red blood cells as little gymnasts, and it's a really complicated gym. And as they're squeezing through all the fibrosis, they can get squeezed out into an abnormal shape. And that can happen in myelofibrosis. It can also happen in thalassemia. As I mentioned, bone marrow infiltration is the underlying pathophysiology there. We're getting close to the end here. Two more images. This one again breaks my rule of veering away from benign hematology. I'm biased, of course, but I think this is really beautiful. It's a beautiful cell for a terrible disease. And it's not really a red blood cell. So 2 strikes against me there. But what disease is associated with this particular image? If you know, go ahead and put it in the chat. Infectious mononucleosis is a great idea. And the reason it's a great idea is because what you can see in infectious mononucleosis are atypical lymphocytes. And when we say atypical, what we mean is that the NC ratio looks a little bit off. But the reason I think this is something a little bit rarer and a little bit stranger is because you almost see flowers. So this is called a flower cell. And the flower cell is associated with adult T-cell leukemia lymphoma. The rosettes, exactly. That's another word for it. Wonderful. So what virus, and I'll give you that clue, what virus is associated with adult T-cell leukemia lymphoma? I've got 1 correct answer so far. 1 correct answer. Perfect. HTLV1. So it's a T-cell lymphotrophic virus. That's human T-cell lymphotrophic virus 1. That's what HTLV stands for. Someone put in the chat an excellent guess, which was that this looked almost cerebriform, which I agree. This was a sort of a really tough question because it sort of looked like a couple of different things. Remember, the cerebriform nuclei would be associated with Sézary syndrome. And so in that sense, you're sort of right, because it's a peripheral cutaneous T-cell lymphoma. And so it was very, very close to what this was. Excellent, excellent guess. And here we have our 14th and our final image. We see these really dark stained inclusions. Dark stained inclusions. Someone mentioned it before, actually. And I'll give it to you that it's also a splenic problem. And it's very closely related to the G6PD stuff. And folks are absolutely right. This is a Howell-Jowell body. I mentioned already, it has to do with hyposplenia or asplenia. And you can see the splenic macrophages typically remove these, and then you might see bite cells. Okay. That is 14 high-yield red blood cell disorders. It is a big chunk of hematology, and hopefully that was useful in terms of correlating basic science to clinical presentations to sort of histology, peripheral blood smears. I admit upfront, it's no way that in 50 minutes to an hour we can cover every possible red blood smear, but these are some of the high-yield ones. I will just make the point again that if you feel like you need help with anything, or if you want to work with someone who is passionate about teaching, let us know. There's a bunch of different ways in which we can get involved. But most importantly, we do have a few minutes for questions. Feel free to send a question to myself or the panelists or to everyone, and I'll do my best to answer them. Here you go. So I'll hang out for a couple of minutes, answer any questions you might have. Remember that Howell-Jowell bodies can basically be correlated with clumped up DNA. It's not necessarily specific for any one thing in particular, but asplenia, like I mentioned, is probably the most common one. And anything that you can that can get rid of the spleen can then lead to this. Like I mentioned, trauma, sickle cell disease, autoinfarction, severe hemolytic anemia, stuff like that. I'll give it another 30 seconds for any other questions. And if folks don't have any questions, I wish you all a great afternoon, evening, wherever you're at. Good luck with your exams, with your studies. I know it can be a big grind. And ultimately, this is just one more step on to becoming what you went to school to actually do, which is to take care of patients. I will say that if you all have suggestions for other topics that you'd like to see in a webinar, we're always keen to really serve you all and give you information that is useful to you. Go ahead and contact us, and we'll see if we can make something happen. All right. And with that, we'll call it an evening. Good luck, everyone. Have a great evening. Bye.